I think the payer's perspective on the currently single approved therapy for SMA, and then sort of looking forward, having multiple treatment options available, starting in the next several weeks, with the potential approval of Zolgensma, is that number one, our members or payers' members are really sort of in this specific instance for the first time able to sort of realistically have hope of their child in most cases doing far better than they did before. And that's the biggest headline message is, hey, sort of this is what we're supposed to be doing in medical science and sort of clinical care of patients is exactly, I don't want to call them the poster vulnerable population, but a population with a rare condition that has some unique characteristics, but really for the first time has treatment. So that's fantastic. I think one of the things that's very challenging about this scenario, before I get to just talking about costs, is assessment of value. And that's, we don't know what the sort of longevity and durability of the treatment is. And people usually think about longevity in terms of the sort of patient, but here as we're just about on the cusp of sort of viral delivered gene therapy, sort of at the onset really, or as close to the onset of sort of clinical manifestations of the disease being administered. Now the question becomes, how long does this method for producing the protein that we want continue to work, or does the body find some way to be able to decrease those levels? And then what happens then? Does it require a boost? And without getting into a lot of the sort of nitty-gritty science of it, which is incredibly fascinating and impactful, there are a lot of questions about what happens over a certain period of time. And so the implication of that from the payer perspective is that since we're dealing with 2, maybe 3 different mechanisms of action between the viral AAV delivered gene therapy and this antisense oligonucleotide treatments already on the market, and then future treatments that sort of are also in the pipeline, the question of combination therapy becomes important. So in the 12 patients who received the gene therapy, higher dose gene therapy, after the follow-up period of 24 months, 5 of them went on to receive nusinersen. And so I won't even sort of dub it a cost perspective, but really from a value perspective, the question is how much benefit incrementally does that combination give you? And regardless of what the price of the gene therapy is, if it's $1.5 million or $4 million, if you add on to that $750,000 in year one, and then somewhere around $375,000 to $500,000 in every subsequent year, you're dealing with these massive numbers. And then as more combinations, because we're progressing science, as more combination therapies become available, that becomes tougher and tougher to wrestle with when it's not just SMA alone. It's 8, then 20, then 40, then 55 other things over the next sort of 5 years or so. I would say that payers' definition of disease modification really depends heavily on what the expected trajectory is for that patient. And with something like this, with spinal and muscular atrophy, the trajectory of each patient is the trajectory of each patient. You can categorize them, and that's the purpose in some ways of the sort of diagnostic category, the types 1 through 4, or even type 0 or pre-symptomatic. But I think the best answer to that is that yes, absolutely, no change in milestones might be considered a win, right? Might be considered real kind of modification of the disease course. So I think payers generally look at it as, is it a modification? Is it a difference in trajectory for this patient individually when it's something that's as variable in course as this is, as SMA is?